Hello, everyone. Welcome back. This is Mike. Today, we'll continue our discussion on respiratory disorders, diagnosis, management, and prevention. Our topic will be restrictive lung diseases, and we will talk about adult and neonatal respiratory distress syndrome. Restrictive pulmonary diseases is a group of disorders characterized by reduced lung expansion and reduced total lung capacity, causing difficulty of breathing. This can be caused by chest wall abnormalities due to bony abnormalities or neuromuscular disease. They include various interstitial lung diseases like pneumoconiosis, sarcoidosis, and immunologic disorders like SLE, PSS, Wegener's granulomatosis, and Goodpasture syndrome. It can also be caused by respiratory distress syndromes, both adult and neonatal, which are acute conditions due to hyaline membrane formation that cause impaired respiratory gas exchange and hypoxia. Both FEV1 and FVC are reduced proportionately, resulting in normal FEV1-FVC ratio. Acute respiratory distress syndrome, or ARDS, occurs when fluid builds up in the alveoli, depriving the body of the oxygen needed to function. Many people who develop ARDS don't survive. The risk of death increases with age and severity of illness. Of the people who do survive ARDS, some recover completely, while others experience lasting damage to their lungs. It is produced by diffuse alveolar damage with resultant increase in alveolar capillary membrane permeability with leakage of protein-rich fluid into the alveoli. This results in the formation of intraalveolar hyaline membrane composed of fibrin and cellular debris. This also results in impairment of respiratory gas exchange and hypoxia. X-ray presents with bilateral lung opacity, known as whiteouts. This is initiated by damage of alveolar capillary endothelium and alveolar epithelium, called type 1 pneumocytes, by the following mechanisms. First, neutrophils release elastase and other toxic substances. Microemboli results from activation of coagulation cascade. And lastly, oxygen toxicity due to oxygen-derived free radicals do even more damage. Signs and symptoms can vary in intensity, depending on its cause and severity, as well as the presence of underlying heart or lung disease. They include 1. Severe shortness of breath, 2. Labored and unusually rapid breathing, 3. Low blood pressure, and lastly, confusion and extreme tiredness. What are the causes of ARDS? The mechanical cause of ARDS is fluid leaked from the smallest capillaries in the lungs into the alveoli, where blood is oxygenated. Normally, a protective membrane keeps the fluid there in the vessels. Severe illness or injury, however, can cause damage to the membrane, leading to the fluid leakage of ARDS. The underlying cause of ARDS include 1. Sepsis. The most common cause of ARDS is sepsis, a serious and widespread infection of the bloodstream. 2. Inhalation of harmful substances. Breathing high concentration of smoke or chemical fumes can result in ARDS, as can aspirating vomit or near-drowning episodes. 3. Severe pneumonia. Severe cases of pneumonia usually affect all 5 lobes of the lung. 4. Head, chest, or other major injury. Accidents such as falls or car crashes can directly damage the lungs or the portion of the brain that controls breathing. 5 is coronavirus disease 2019 or COVID-19. People who have severe COVID-19 may develop ARDS. And lastly, other cause includes pancreatitis, which is an inflammation of the pancreas, massive blood transfusions, and burns. What are the risk factors of ARDS? Most people who develop ARDS are already hospitalized for another condition, and many are critically ill, especially those with sepsis. People who have a history of chronic alcoholism are at higher risk of developing ARDS. They are also more likely to die of ARDS. Complications of ARDS while hospitalized include the following. First, deep vein thrombosis, DVT. Lying still in the hospital while on a ventilator can increase risk of developing DVT, which can break off and cause pulmonary embolism. 2. Pneumothorax. In most ARDS cases, a ventilator is used to increase the oxygen in the body and force fluid out of the lungs. However, the pressure and air volume of the ventilator can force gas to leak out of the lung and cause it to collapse. Third, infections. Because the ventilator is attached directly to a tube inserted in the trachea, this makes it much easier for lung infections to occur. And lastly, pulmonary fibrosis. Scarring and thickening of the tissue between the alveoli can occur within a few weeks of the onset of ARDS. This stiffens the lungs, making it even more difficult for oxygen to diffuse from the alveoli into the bloodstream. What about long-term complications of ARDS? They include 1. Breathing problems. Most people recover most of their lung function within several months to 2 years, but others may have breathing problems for life. Even people who do well usually have shortness of breath and fatigue and may need supplemental oxygen at home for a few months. Second is depression. Most ARDS survivors report going through a period of depression which is treatable. Third, there are problems with memory and thinking clearly. Sedatives and low levels of oxygen in the blood can lead to memory loss and cognitive problems after ARDS. And lastly, tiredness and muscle weakness. How is ARDS diagnosed? There's no specific test to identify ARDS. The diagnosis is based on the physical exam, chest X-ray, and oxygen levels. It's also important to rule out other diseases and conditions that can produce similar symptoms. Imaging tests that may be requested include 1. Chest X-ray, which can reveal which parts of the lung and how much of the lungs have fluid in them and whether the heart is enlarged. Second is computed tomography, or CT scans, which can provide detailed information about the structure within the heart and lungs. Blood tests, which would include arterial blood gas, complete blood count, and sputum culture and sensitivity. Tests to rule out cardiac problems include 1. Electrocardiogram, which tracks the electrical activity of the heart, and 2. An echocardiogram, which is a sonogram of the heart and can reveal both structural and functional problems of the heart. How do you treat ARDS? The first goal in treating ARDS is to improve the levels of oxygen in the blood. Without oxygen, the organs can function properly. First, supplemental oxygen will be delivered through a mask that fits tightly over the nose and mouth. Next, mechanical ventilation. Most people with ARDS will need the help of a machine to breathe. A mechanical ventilator pushes air into the lungs and forces some of the fluid out of the alveoli. Next is fluids. Carefully managing the amount of intravenous fluid is crucial. Too much can increase fluid buildup in the lungs. Too little can put a strain on the heart and other organs and lead to shock. Lastly are medications that prevent and treat infections, that relieve pain and discomfort, that prevent blood clots in the legs and lungs, that minimize gastric reflux, and lastly, that sedates the patient. Now what about lifestyle changes? First, quit smoking and avoid secondhand smoke whenever possible. Second is to get vaccinated. The yearly influenza shot, as well as pneumonia vaccine every 5 years, can reduce risk of lung infections. Now let's discuss neonatal respiratory distress syndrome. A full-term pregnancy lasts 40 weeks. This gives the fetus time to grow. At 40 weeks, the organs are usually fully developed. If the baby is born too early, the lungs may not be fully developed, and they may not function properly. Healthy lungs are crucial for overall health. Neonatal respiratory distress syndrome, or neonatal RDS, may occur if the lungs aren't fully developed. It typically occurs in premature babies. Infants with neonatal RDS have difficulty breathing normally. Neonatal RDS is also known as hyaline membrane disease and infant respiratory distress syndrome. Now, what causes neonatal respiratory distress syndrome? Surfactant is a substance that enables the lungs to expand and contract. It also keeps the small air sacs in the lungs known as alveoli open. Premature infants lack surfactant. This can cause lung problems and trouble breathing. RDS may also occur because of a development problem linked to genetics. What is the pathogenesis of neonatal RDS? First, the role of surfactant. The function of surfactant is to reduce surface tension within the lungs, facilitating expansion during inspiration and preventing atelectasis during expiration. The composition of surfactant includes dipalmitoyl lecithin and is secreted by type 2 pneumocytes. Now, fetal pulmonary maturity is assessed by measuring surfactant lecithin to sphingomyelin ratio in amniotic fluid. A ratio of 2:1 or greater lecithin to sphingomyelin indicates pulmonary maturity. Now, what are the predisposing factors? First is prematurity. Gestational age greater than 28 weeks has 60% incident rate. Second is maternal diabetes mellitus. Third is birth by cesarean section. And lastly, multiple gestations. What risk factors predispose to neonatal RDS? The lungs and the lung function developed in utero. The earlier an infant is born, the higher the risk of RDS. Infants born before 28 weeks gestation are especially at risk. Other factors include a sibling with RDS, multiple pregnancy, twins or triplets. Third is impaired blood flow to the baby during delivery. Fourth is delivery by cesarean. And lastly, maternal diabetes. What are the symptoms of neonatal RDS? An infant will typically display signs of RDS shortly after birth. However, sometimes symptoms develop within the first 24 hours after birth. Symptoms include the following. 1. Bluish tint to skin, flaring of nostrils, rapid or shallow breathing, reduced urine output, and grunting while breathing. How is neonatal RDS prevented? First, preventing premature delivery lowers the risk of neonatal RDS. This can be achieved by consistent prenatal care throughout pregnancy and avoiding smoking, illicit drugs, and alcohol. If a premature delivery is likely, the mother may receive corticosteroids to help promote faster lung development and production of surfactant, which is very important to fetal lung function. Next, what are the complications of neonatal RDS? Neonatal RDS may get worse over the first few days of a baby's life. RDS can be fatal. There may also be long-term complications due to either receiving too much oxygen or because organs lack oxygen. They include 1. Pneumopericardium, 2. Cognitive disabilities, 3. Pneumothorax, 4. Bacteremia or septicemia, 5. Renal failure in severe RDS, 6. Bronchopulmonary dysplasia precipitated by treatment with high concentration of oxygen and mechanical ventilation, 7. Patent ductus arteriosus due to failure of closure of ductus caused by immaturity and hypoxia, 8. Intravascular brain hemorrhage, and lastly, necrotizing enterocolitis because of fulminant inflammation of the small and large intestine. How is neonatal RDS diagnosed? First, lab tests rule out infections that could cause breathing problems. Next are chest x-ray to examine the lungs. And lastly, a blood gas analysis that will check oxygen levels in the blood. How do we treat neonatal RDS? When an infant is born with RDS and symptoms are immediately apparent, the infant is usually admitted to the Neonatal Intensive Care Unit or NICU. The main treatment for RDS are surfactant replacement therapy, a ventilator or nasal continuous positive airway pressure and CPAP machine, and oxygen therapy. Surfactant replacement therapy gives an infant the surfactant they lack. The therapy delivers a treatment through a breathing tube. This ensures it goes into the lungs. After receiving the surfactant, the doctor will connect the infant to a ventilator. This provides extra breathing support. They may need this procedure several times depending on the severity of the condition. The infant may also receive ventilator treatment alone for a breathing support. A ventilator involves placing a tube down into the windpipe. The ventilator then breathes for the infant. A less invasive breathing support option is nasal continuous positive airway pressure or NCPAP machine. This administers oxygen through the nostrils by a small mass. And lastly, oxygen therapy delivers oxygen to the infant's organs via the lungs. Without adequate oxygen, the organs don't function properly. A ventilator or NCPAP can administer oxygen. In the mildest cases, oxygen can be given without a ventilator or nasal CPAP machine. This ends our discussion on respiratory distress syndromes. See you next time when we discuss the pneumoconiosis.